Good afternoon, folks. We are giving everybody just another minute or two to get joined in to our presentation today. Um, we are recording today's session and we will get started here just in another minute. All right, so we welcome everybody to today's session with our series, our three-part series around the promoting interoperability category. This is webinar number 2. Just some real quick housekeeping items. If you have any questions during the presentation, please put them in the chat and we'll address them at the end of the day. As I mentioned, we are recording today's session and we will have that link available within the next week, and you'll receive an email with the recording that you can share within your organization. Real quickly, the information contained in this presentation is for general information purposes only and does not attempt to provide any medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. If you've been working with us for a while, you know that we offer several other services in addition to our individualized assistance for the quality payment program. If you have not worked with us on any of these but would like more information, by all means reach out. And we always take pride in showing off our team here. So this is from a photo from last summer. We'll be refreshing that later this year. We also like to talk about all of the clients that we have across the state, whether they're hospitals or clinics. All of these healthcare organizations are who provide health to our community. And so we work very hard to be the trusted advisor to all of these healthcare organizations, clinicians, and leaders to manage this complex and changing world of healthcare. As last month, and again this month, I have my colleagues Jerry Deason and Vicki Harden with us. And you all will get us one more month next month in April. So today's presentation is a continuation of last month's webinar. This is a three-part series devoted to the promoting interoperability category of the quality payment program. As mentioned earlier, if you didn't receive the link to our February presentation, reach out to your advisor and they'll be sure to send that on. Today, we'll have a real quick review of the category and then jump right into 2 of the objectives within the promoting interoperability category, discuss scoring and data submission for attestation, and then next month's meeting will focus on the health information exchange measure. So real quickly, as an overview, the promoting interoperability category is part of all forms of the QPP program. So whether you're submitting through traditional MIPS, an MVP, or an alternative payment model, promoting interoperability is part of that program. For traditional MIPS, it still remains at 25% of that final score. It has been that way for several years, and we don't look for it to change. You must report a 1 in the numerator, or answer yes, or report an exclusion to all of the measures. They have to be scored, or you will not receive any credit for the category. You must have an EHR that's been certified to the current ONC regulation, connected to a public health registry. Reminder for those of us here in Kentucky, most everyone's connected to KHI. And then the reporting time frame of 180 continuous days within the performance year is the new minimum. And then annually complete your SRA and attest to the safer guides. So jumping right into the objectives, we're starting with the e-prescribing. So this is at least one permissible prescription is written by the MIPS eligible clinician, is transmitted electronically using a certified health record. The denominator is prescriptions written for all drugs requiring a prescription in order to be dispensed. This could be all medications that include your controlled substance, or you could just do all medications without controls. And then the numerator is all prescriptions that are generated. Sorry. So eScribe Objective actually has two measures, but this first one has to do with sending the prescription electronically. This measure's been around pretty much since the inception of meaningful use, but it has had some updates. The one thing that hasn't changed is that ability to include or exclude your controlled substances in your report. And so oftentimes you all will see when you pull your PI reports down that you'll have two numerators and denominators for this measure. When meaningful use first rolled around with attestations, there were many states that didn't allow prescribing for controlled substances. Maybe skilled nursing facilities couldn't accept them, or in some states, Medicaid did not allow the electronic prescribing. That has since changed for many areas, but CMS has recognized that these would be concerns, so they have continued to leave it up to the provider on how to report that numerator and denominator. And at one point in time, we saw that it maybe had impacted their performance rate, but lately what I have saw with my clients is it hasn't really made too much of a difference. The variation is really low. E-prescribing is a must-pass measure by either taking an exclusion or reporting the numerator and denominator. And for this measure, well, for the entire category, you have to have that 180-day minimum reporting period, and you have to use the same reporting period for all measures. You can't have one for eScribe and a separate one for HIE. And the performance points are based on a 1 to 10 scale. Prescriptions that are not included in this measure include for over-the-counter medications or any kind of durable medical equipment. If by chance a patient requests a paper prescription, you can still do that, but that patient will still be included in the denominator for receiving that prescription. So e-prescribing exclusions, we do have an exclusion for this particular measure. At one point we had two. This exclusion here is that you wrote fewer than 100 permissible prescriptions. We used to have the other exclusion where if you didn't have a pharmacy within 10 miles, that could accept an exclusion, but that one is no longer available. Regardless if attesting at the individual or the group level, in order to claim this exclusion at the group level, the entire group total denominator must be less than 100 prescriptions. It's not cumulative by provider. So if you have two providers who want to attest together underneath the tax ID number, that denominator to take this exclusion has to still be less than 100 permissible prescriptions. If you elect to take the exclusion, those performance points are distributed to the health information objective. So some challenges that we see and some best practices that we have utilized. Originally, we saw a lot of provider resistance and we had patient preferences. And sometimes pharmacies lack the necessary infrastructure. And we know that this process is not always perfect. There are often times that the whatever link it is to that particular pharmacy sometimes gets broken. And you can have a clinician that's just positive that they have e-scribed all of their medications, and then that patient calls you and says the pharmacy doesn't have their medication ready for them because they never got the order. So that continues to be an issue, but I think it's fewer than it has been in the past. Providers now are coming out of medical school trained on an EHR, so provider resistance is getting less and less. Best practices include verifying patient information, always verifying their pharmacy that they prefer to use so that that's at the top of the list for the provider. And granted, not all pharmacies are open 24 hours, so they have to make changes, but make sure it's the preferred for the visit that particular day. Lots of EHRs have clinical decision interventions and workflows available. We encourage you to make sure those are all enabled so that they have those in front of them. Those support tools include things like checking for drug interactions with whatever's on the patient's medication list, making sure there's no interference with any medication allergies and or food allergies, or any other contraindications prior to prescribing. And then monitor this e-prescribing workflow. We have another project where we recognize that if a provider makes an error in the prescription when they place the order, that it's not, it's harder to remove that prescription from the list. And so sometimes it's showing duplicate orders for the same medication. So monitor your e-prescribing activities for inefficiencies, errors, opportunities for improvement. Maybe there's some guidance out there on prescribing practices. Sometimes we see things regionally on how things are ordered or what medications are used. And then monitor your prescribing patterns. We'll talk about Casper here in a minute, but there's you can do a reverse and look at prescribing patterns that way as well. Kentucky does have mandatory requirements for electronic prescribing of controlled substances. And in this case, both providers and pharmacies have to comply with those regulations. And typically insurance tends to follow that lead as well. So that's another indication for monitoring your prescription patterns. So at this point, I'm going to pass this over to my colleagues, and they're going to take over with prescription drug monitoring.
Thank you, Robin. So I'm going to talk to you a little bit about the second part of the e-prescribing objective, and that is the query of the PDMP program. So PDMP stands for Prescription Drug Monitoring Program, if you was not aware of what the acronym meant. This is an electronic database that tracks controlled substance prescriptions. Drug monitoring programs helps our eligible clinicians to identify those potential drug abuse or patients who may be at risk for overdose. If a eligible clinician electronically prescribes at least one Schedule II opioid or Schedule III or 4 drug via their electronic health record, they are required to use data from a certified database to conduct a query of a PDMP for that prescription. So some highlights of the PDMP program. It is a must for promoting interoperability performance category. You must attest yes or no. By attesting yes, you will receive the full 10 points. Of course, if you attest no, you're going to receive 0 points and you're not going to pass the e-prescribing objective measure. Of course, what Robin said previously, you must submit data for a minimum of 180 consecutive days within the calendar year. And then you must query that PDMP prior to the electronics transmission. And that has to be dated and noted on that query. Eligible clinicians have flexibility to query the PDMP using data from a certified database allowed under the state law. And that's kind of where your CASPRO program comes in. And we'll talk a little bit more about that in the next couple of slides. So there is a couple of exclusions for the PDMP objective. So the first exclusion is that if an eligible clinician is unable to electronically prescribe any Schedule II opioids or any Schedule 3 and 4 drugs in accordance with applicable law during the performance period. Or if they do not electronically prescribe any Schedule 2 opioids or Schedule 3 or 4 drugs during the performance period. So there is a couple of exclusions there. So why would an eligible clinician not be able to prescribe a Schedule 2? What are some of the reasons why an eligible clinician could not prescribe Schedule 2 or Schedule 3 or 4 drugs? A few things we have seen with our clients, and then of course with my past experience working with an FQHC, it could be due to lack of DEA identity proofing. There is an identity proofing process that the provider has to complete before they receive their licenses, and it is pretty stringent, and it can be frustrating to the provider. Also, if the DEA registration is not currently active, it's expired, or they just basically haven't registered just yet, that can put a slowdown in being able to query PDMP. That could be your exclusion for not submitting for this objective. Or the EHR may not support prescribing for the Schedule 2, 3, and 4 drugs. Most EHRs that we work with, they have that functionality. That is kind of that was a common issue in the beginning, but of course, as we've moved forward with our technology and our EHR functionalities, this is not a major issue anymore within the healthcare organizations. So if you do claim an exclusion for this category, 10 points will be distributed to the e-prescribing objective that Robin was just talking about. So those 10 points will move to that objective. All right, so talking about that certified database that you have to utilize to query the specific drugs that we talked about. For in Kentucky, all of our providers, a lot of organizations use the CASPR database. Okay, and the CASPR database is the prescription monitoring system, and it's designed to be that source of information to assist providers and pharmacists with providing medical and pharmaceutical patient care using those controlled medications. And that's basically what CASPR is. What we wanted to make you kind of aware of is KHI has it's a newer integration. This has not been around. This is like it's been, I did a review on the CASPR integration into KHI and the ePartner viewer. And this is just kind of new. This is just a newer application. But it offers CASPR users the ability to view CASPR data in KHI through the ePartner viewer. So if you are familiar with ePartner viewer, and if you utilize ePartner viewer, you're going to and if you are a registered user of CASPR, and you went through all of that process of creating your account and doing all of that great stuff that it requires you to do, you're going to see a additional portlet in the dashboard that will display the PDMP report. And you can do this all within the ePartner viewer. You don't have to go outside of the ePartner viewer to the CASPR system to actually to query a certain patient prescriptions. So this is a really nice feature that KHI is just beginning to offer. So if you are familiar with ePartner viewer, you will see this portlet pop, kind of appear on your dashboard, so you can begin using it with internally within KHI's ePartner viewer. But also, CASPR, you can also query these prescriptions through the CASPR website. And like I said in the previous slide, be sure and query these prescriptions or these patients' prescriptions before the actual encounter occurs. All right, so moving on to the next objective in the promoting interoperability category is provider to patient exchange. So this has to do with the number of patients in the denominator who are provided timely access to the health information, to their health information to view online or download it or transmit to a third party, and to access using an application of their choice that is configured to meet the technical specifications of an API in the eligible clinician cert. Okay, so let's break this down a little bit. So what is an API? API is an application programming interface. It's a set of rules that allow different applications to communicate with each other. APIs may be enabled by healthcare providers or organizations to provide their patients with access to their health information through a third-party application. Most commonly, of course, would be the patient portal via the EHR. Some other examples of APIs would be Apple My Health. That is an API. They kind of taught it, the information that it collects on your watch or whatever, it talks back to your dashboard and gives that information, and it updates that information whenever you sync the two applications together. Another example is Google Maps. That's an API. Your HL7 lab results that come in, that you have set up, that comes in from your hospital labs or wherever your labs are being read, those results come in through an HL7. That's an API. So those are some examples of APIs that can cover, it covers a broad range of different areas of our lives. And back to the patient portal, that covers that broad range of healthcare needs, such as that health tracking and that patient data management. So that is kind of a really short, brief summary of what an API is. Provide access. It talks about timely access. What is timely access? So we define timely access as within 4 business days of the information being available to the eligible clinician. So what access are we providing? So when a patient possesses all of the necessary information needed to view, download, or transmit their information, that meets the criteria of providing access. So this could be instructions on how to access the information by providing the website address, creating a username and a password, instructions on how to log in. So that meets that providing access criteria. And then, of course, you have your unique patient, and that's going to be a patient that is seen by that eligible clinician more than once during the performance period. However, if they are seen more than once, is only going to be counted one time. So it's kind of an unduplicated patient count. This is a required measure for promoting interoperability. You can, for this measure, you can score up to 25 points, depending on your performance rate from your denominator and numerator. And then also, again, you must submit data for a minimum of 180 consecutive days within the calendar year. All right, so improving performance in the provider to patient exchange. So these are some suggestions and recommendations that we kind of give to our clients when they're looking at the performance rate for this specific objective. So kind of understand what your vendor is looking for there. What triggers that numerator? Is it downloading the application? Is it logging in? or is it just basically pushing an invite to your email address for the portal? So kind of knowing what the specifications from your vendor requires is really important to know. On the patient level, make sure post information on the portal, or post information that they can see what is included in their portal. Offer to set up that portal with them at visits, or even by phone if they need assistance. Send reminders via email and text to let them know that they do have some information loaded to their portal, and add instructions on how to log in into that portal. For staff, promote the interactive functionality of the portal. Um, like you're able to send messages to your provider, and when there's a concern, and you'll receive a timely response. Kind of let the building that relationship between the provider and the client by using the patient portal. And then what's on the horizon? So there's a lot of discussion about integration of third-party apps, such as your Apple Health, your Google Fit, those types of apps that I know I use, and I'm sure a lot of people are, they really rely on their Apple Watch or their Google Fit Watch to make, to see how many steps they have, completed today, or what their heart rate is, things like that. But there is a huge push in the healthcare organization world to kind of integrate these third-party apps with your current API of the patient portal. It's not universally implemented just yet. However, they are beginning to explore and look at these different types of integrations and how it would best suit the patient, and what and the benefits that the provider would receive by having that integration completed, or having that integration installed along with your patient portal. All right, so I am going to pass it off to Jerry to talk a little bit about scoring.
Thank you, Vicky, and good afternoon, everyone. So we've talked about how to maximize your performance across e-prescribing and provider-to-patient exchange. Now let's talk about some points you can earn with these measures and other promoting interoperability objectives. If your organization has been participating in MIPS for a while, you're probably familiar with this slide. These objectives and points haven't really changed much over the past couple of years. But for folks that are newer to the program, I think it's definitely helpful to see the scoring laid out, and it may be a good refresher for everybody else. Points are really broken down into 4 core objectives. There are 20 points available for e-prescribing. You get 10 points to attesting to querying the PDMP or using Casper before you schedule or before you prescribe any of those Schedule 2 or Schedule 3 medications. Eligible clinicians can earn up to 10 points for e-prescribing based on the number of prescriptions generated and transmitted electronically, as Vicky had discussed. Next, we have the HIE objectives, and I'm not going to spend a whole lot of time here. Spoiler warning, our next webinar is going to really drive home how to be successful in this objective. So if you're interested, you really want to get all those 30 points associated with HIE, be sure to tune into the last webinar of this series. But there are 3 avenues to get your points here. Option 1, sending and receiving electronic health information. It's the most basic and simplest form of HIE. It also is the one that requires you to do the most work. You'll notice that this is the only HIE measure that is scored by numerator and denominator performance. This is because it's going to require you to actually make sure you are pushing and requesting that health information. To even be scored on this measure, you will need to send a summary of care record electronically for at least 1 patient. The same is true for receiving and reconciling summaries of care. Have to have at least 1 patient in the numerator to be scored. Receiving HIE requires reconciliation for medications, medication allergies, and current problems. But don't worry, next month we will take a much deeper dive into these measures to make sure that you can maximize your score. But for now, all you really need to know is that half of your points are coming from sending those summaries of care, and half are coming from reconciling and receiving those summaries of care. The other 2 ways I'm going to kind of talk about together. These are yes/no attestations. And really what you're attesting to is that the eligible clinician is connected to and participates in health information exchange that supports bidirectional exchange of health data. The big difference between bidirectional and TEFCA, the newest option in this objective, is where the information is going and who facilitates that HIE. Bidirectional is going to be your utilization and connection with KHI in our state, and TEFCA is your connection to a nationwide HIE or QHIN. Epic and NextGen are two EHRs that also operate as QHINs that can be used for the TEFCA option. There's a handful of other ones out there, but we'll get into that more next month. Next, we have provider to patient exchange, and Vicky did an excellent job of laying out this measure, so I won't harp on it too much, but there are 25 points available here, and it's scored on a numerator denominator performance. It's a pretty good chunk of points here, and we can see clients struggling a little bit with this measure. So really driving patients to utilize the portal and knowing your vendor requirements so that you get credit is really key to getting your PI score up. Lastly, we have the public health and clinical data exchange objective. We discussed the specific measures in our previous webinar of the series. So if you're looking for more information or if you weren't able to attend that webinar, I would encourage you to go check out that recording. But the first component to this objective is the immunization registry and the electronic case reporting. These attestation statements are worth 25 points for the category and require you to be in that active engagement with the registries. Essentially, you are moving towards that production data phase or are in the production data phase of sharing information to these specific registries. I want to remind you that new for 2025, that if you are previously or have previously attested to that option 1 of pre-production and validation stage, you must progress and attest to option 2 this year, that validation, validated data production stage. So start early this year to make sure that you meet the requirements. It can take some time to get everything up and running and get all your ducks in a row. Lastly, we have a chance for some bonus points in the promoting interoperability category. This is about the only thing that you can attest no to in the category. To get an extra 5 points, you will need to attest to reporting 1 of 3, the public health reporting, clinical data reporting, or syndromic surveillance reporting. I want to note that you only get 5 points for doing any of the 3. It's not 5 points per each, unfortunately. But I feel like at this point we should be getting some kickbacks from KHI as much as we mention them. But KHI really is, it makes this easy. It's your one-stop shop for any of these public health connections. So reach out to your KHI coordinator to start the process of getting connected and reaching the active engagement phase. All right. If you were a bit confused about scoring and wondering, well, I don't participate in that, where does my points go if I take an exclusion? We have that all broken down right here for you. If you take advantage of the exclusion for e-prescribing, those 10 points are going to reweight over to the HIE objective that you selected. If you meet the exclusion for PDMP, those 10 points are going to be added to your e-prescribing numerator and denominator performance and make that worth 20 points. If you take an exclusion for receiving and reconciling health information because you received less than 100 of those for the year, those points will be added to sending health information, making sending worth the full 30 points for HIE. If you take an exclusion for the HIE objective as a whole, those 30 points will be added to provider to patient exchange. If you meet the exclusion criteria for one of the 2 public health measures, the points will be added to the other measure that you are testing for. If you take the exclusion for both immunization registry and ECR, the 25 points will be added to provider to patient exchange. Essentially, to keep this really simple, if you take an exclusion for a specific measure, points are going to roll up to another measure in the same objective if applicable. If you meet exclusion criteria for an entire objective, Points are going to roll up to either HIE or provider to patient exchange, depending on that exclusion. If I've completely confused you by this point, I deeply apologize. Just please add your questions into the chat and I'll do my best to explain it in a different light. And please don't hesitate to talk to your advisor as you begin planning and working on promoting interoperability. We can show you on our gap analysis tool exactly how rerating scenarios can take place. Next, we've got submission for the promoting interoperability category. So let's talk about some ways that you can submit. There's 3 ways to submit your data. I'll start here with the way most of us probably do it, and that's by signing in and manually entering your information into the QPP site. You or your vendor can also sign in and upload a PI file from your EHR. And lastly, your vendor can submit on your behalf via an API if they have that capability. I know we work with some EHRs like Athena that has the ability to do this. So if that's something you're interested in, check with your vendor and see if they have that capability. I also want to highlight new for 2025. If there are multiple submissions, CMS will score each submission and assign the highest to you. And let's talk through some submission steps. So as we talked about in the last webinar of the series, you will need to answer those attestation statements. You must attest yes to preventing information blocking. You must submit yes to having reviewed and completed those high priority SAFER guides. Submit yes or no attestation to ONC direct review statement. Submit yes to having conducted an SRA in the performance year. And then you will need to input your numerator and denominator performance, or attest yes that you have completed the objectives we discussed. If your vendor is submitting on your behalf, this is where that'll take place as well. So let's talk now about getting prepared to submit your data. Over the course of the year, you want to be pulling baseline reports to review your scores. Advisors can put this into our GAP tool and give you an idea of what you may score. This can help you identify some areas of opportunity to improve performance. Next, we really recommend you share your performance with your staff and your clinicians. Highlight areas where they are completely knocking it out of the park. And at this time, it's good to have those conversations about things that can be improved. This is a great way to incorporate some PDSAs and try some different interventions to boost your performance. And then ensure all your various agreements are in place by mid-year. July 5th is the start of that last 180-day window of the year, and it sneaks up on you quick. So make sure that you have your SRA scheduled, you have set aside some time for your team to review the SAFER guides, you have all of your public health agreements in place, and the patient portal is functioning correctly. Make sure all your addendums are good to go. And lastly, save all of that information. I can't stress it enough to have all your documents, addendums, agreements stored in a binder labeled with the year, and also have a digital copy of those on a computer. A shared drive works best, so anybody can access those. In the event that CMS does audit your practice, you'll want to have this information on hand. And the last thing I got for you guys is a scoring example here. So let's walk through this together here. In this example, the provider or eligible clinician has an e-prescribe rate of 50%. So they will receive 5 points from there. They query the PDMP, so they'll get the full 10 points associated with that. This clinician participates in an HIE by sending and receiving, and based on their performance, they're going to get 20 points for HIE. He or she also has 50% utilization rate of the patient portal, so that'll tack on another 12.5 points. And the clinician is getting 25 points for public health. So the score is totaled out of 100 points. This provider achieved a raw score of 72.5 points. If you look down there at the blue box below the table, you can see how the category is calculated. So you take that raw score and divide it by the 100 possible points, and then you multiply that by 25 to get your score of 18.1 points that contribute to the clinician's final score. And with that, I'm going to take a brief pause here. If you have any questions, we've got some time left over here. Please drop those in the chat, and Robin, Vicky, and I can answer those for you. Don't see anything coming in. If you have questions later on down the road, please don't hesitate to reach out to us. Robin, Vicky, and I are happy to answer your questions or reach out to your advisor. They will also know the answers to those questions as well. Looking ahead at our webinar schedule, Robin, Vicky, and I are back on April 8th to finish up the Expert Insight series into promoting interoperability, and we'll be discussing how to become a master with health information exchange. And I can't believe we're already talking about May. That's a little crazy to me, but on May 13th, the team will be kicking off our Accountable Care series focused on patient-centered care. Also, want to keep it on your radar here. 2024 MIPS submissions are due by March 31st. So if you haven't yet, get into the QPP site and get those submissions in. And as always, the RAC is here to assist you and be your trusted advisor in the ever-changing, complex world of healthcare we are living in. So do not hesitate to reach out to us with questions concerning any of our service areas. We have a whole host of advisors that are willing to jump right in and offer a helping hand. Shoot us an email, give us a call, or check out our website for more information. The REC is also on Facebook, X, LinkedIn, and we'd love to connect with you on those platforms as well. Thank you, everybody, for tuning in today. Have a wonderful rest of your day and get out there and enjoy this beautiful weather. We will be back and see you all next month.